Hi, everyone. This is Joe Young, Global Data Systems. I appreciate your taking the time to listen into the second of our four-part webinar series on MACRA. Of course, I have Jen Monahan here, partner with Health One Technologies. Our first webinar, Jen did a high-level overview of MACRA and some of the measures that you're all faced with and going to be affected by. And today, she's going to do a deep dive into the MIPS quality measures. And as always, we'll be recording this webinar so that if for whatever reason you have to get off or can't stay on for the entire time, we can send this to you. And with that, I'll send it over to Jen.
Okay, thank you, Joe. Welcome back to those of you that attended the last webinar, and welcome to those of you that might be watching this series for the first time. Today, what we're going to talk about is, first of all, I'm going to do a quick review of what we talked about at the last webinar, and then the majority of this session is going to be a really deep dive review into the quality portion of the MACRA MIPS program. So just a quick overview of what our objectives are. I'm going to try to limit the overview to 1 minute. So just a quick recap of the last session. We're going to talk about the quality measures, the description overall, like what CMS is kind of saying about the quality measures, requirements so that we know what we have to do with the measures, exceptions to the requirements, individual and group reporting options. We're going to talk about how we submit quality measures, how they're scored, including base and bonus points, and then where you start in the program, what you're going to do to kind of get things going underway with your quality metrics. So for our quick overview of the MACRA program, these were the things that I felt were most important out of our previous webinar to recap and make sure everybody understands. So key dates. We know that the program takes effect as of January 1st of 2017. We're going to report that data sometime before March 31st of 2018, and the payment adjustments are going to begin on January 1st of 2019. So there's a whole lot of other milestones that happen in between those key dates, but I think those are the ones that are most important for us to be aware of. And the other thing is who's eligible to participate in 2017. Again, this particular eligible clinician area will change 2019 and forward, but for today and for the sessions that we're doing, we're just talking about 2017. So physicians, PAs, nurse practitioners, clinical nurse specialists, and CRNAs, those are all people that are eligible to participate in 2017. And then the third portion is just how the MIPS program is broken up so that you can see the pie chart. 60% of the pie is quality. That's what we're going to speak about today. 25% is advancing care information. That will be in our next webinar. And then the last smallest portion is improvement activities, and that will be in the final webinar of our series. Quick review of a financial calculator so that we're reminded why we're doing all of this. This sample financial calculator is based on a practice that has $1.5 million in Medicare revenue. As you can see, the incentives, the base incentive or penalty is 4%, and then there's also some exceptional performance bonuses that go all the way to 10%. So in an organization like this that has $1.5 million at stake, the penalty could be anywhere. It's going to be roughly $60,000. Could be a little less depending on how things participate, but at the max, that's what that penalty is going to be. And then the incentive dollars, the base incentive dollars reflects the penalty, the budget neutral program. In addition to that, we have the exceptional bonuses that are available, and that goes all the way up to 10%, and that's from a different kitty of money. Basically, there's $500 million that fund that exceptional bonus money. That's something I do want to make sure. I had a couple of groups call me after the last webinar and they weren't understanding about that exceptional bonus money, but that is separate from the base incentive and penalty, and I think that's an important number to look at, because in a group like this, they have $150,000 that could be available as exceptional performance money to them. And then lastly, just in 2017, what our options are for reporting. So we can do the very, very minimum to avoid a penalty, that's called the test piece. We can do a partial year, which is a 90-day reporting period, or we can do a full year. So those are the three options that we have for 2017. So let's talk about quality measures, because this is the part of the pie that makes up 60%. And just a couple key elements on here. I thought it was important to kind of mention little tidbits of information that I'm finding in the final ruling that I thought would sort of set the tone for what CMS has put out there. So the quality measures are very similar to what we have been doing for PQRS in the past. So anybody that's attested or done any reporting with PQRS, it's very, very similar underneath the MIPS program. The difference is under MIPS, PQRS just makes up one component. It happens to be 60% this year, but it is just one program or one component of the program as a whole. As I was reading the final ruling, CMS actually put a couple of informational things in there, and I thought I'd put these on the screen and share with everybody, because they have done a good job of saying that, you know, they're trying to make it so that it's flexible and meaningful to people. And they actually use these words. This is a bullet list that I took right from the final rule. But their goal is to have it so that the measures are relevant and meaningful to you as physicians and your practices. So it's something that as we go through the process, we don't want to choose measures necessarily just because it's something that's easy to be ticked off the list. We want them to be relevant and meaningful to your clinical practice. We also want to maximize your EHRs. So we went through meaningful use. We've gone through the process of implementing these technologies into our practices, and now is the time to leverage and optimize those so that we can get meaningful data in and out of the system. Under the MACRA program, they've allowed a lot of flexible scoring, so people can participate at whatever level that they want. If you want to participate at a minimal effort and avoid penalty, you can do that. And then they also have set up rewards for people that want to practice or participate at a higher level. The measures that they've designed are meant to be around workflows that we already do, data that we may already be capturing. We just need to kind of fine tune it and tweak things a little bit. And then lastly, just providing a scoring mechanism so that we know who the low and high performers are, which is ultimately the goal of this MACRA program. We're focusing on a quality payment system. So knowing who's scoring high and low is an important factor. Requirements for the measures under the quality portion. So most eligible clinicians and groups, and I'll explain that a little bit later in the slide, but we must select a minimum of 6 measures. So in the past, in PQRS, we had to select 9 measures, and they had to be under different domains. They had to cross multiple domains. With the quality program, we only need to do 6, and they do not need to be across the domains as they had been in PQRS. One of the measures that we select must be an outcome measure. If there is not an outcome measure that works for you, then you have to choose another high priority measure. But one of them has to be preferably an outcome. If not, then we go to a different high priority measure that we could select from. And then also there was a lot of discussion about cross-cutting measures in 2017. They have taken that out for a transition for 2017. I think that may come back in, but we don't need to worry about cross-cutting measures at this point either. A couple other small things to notice. Eligible clinicians and groups, again, we have to report on 50% of the patients that meet the denominator, and that's across all payers. So that's an important thing to know. In meaningful use, if some of you have participated in that, you can remember that we reported against all patients, whether or not they were Medicare. It's the same concept with quality measures. As we're reporting this data, we're not separating who's Medicare and who's Blue Cross and who's Aetna. We're reporting across all payers of 50% of our patients that meet the denominator. And then the other key factor is, as we pick our measures, we have to have, in order to get a performance score, we have to have at least 20 cases that fall in the denominator. So if you want to pick a measure that has only a couple of patients, you're not going to be able to get a higher performance score on that. You will get the base minimum, but you won't get a higher performance. So we want to look at measures that have enough patients in the denominators to meet that 20 case threshold. So that's another important factor to keep in mind. What are the exceptions? So the exceptions are pretty limited on this one. There's an interesting one with CMS has defined specialty sets, and they are available for most specialties. Actually, I think just yesterday, however, for nephrology, and nephrology does not have a specialty set, so that's just a little FYI out there. But most specialists, there is a specialty set to choose from. If there are fewer than 6 measures in that specialty set, you don't have to do 6 measures. You just do the measures that are included in that specialty set. So for instance, interventional radiology, I believe, only has 3 measures. So they're only going to need to report on those 3 measures to make the requirements for the quality program. You're not penalized in any way. They adjust the final score. They just kind of weight it a little bit differently, but you don't have to go above and beyond your specialty set. So they've built in some flexibility to allow for those specialists that may not necessarily have a lot of patient-facing interaction, and they've kind of said, okay, we think these ones could be relevant to you, but you don't have to do more than that. So that is an exception to the requirements for quality. Individual and group reporting. So I've gotten a lot of questions about this over the past few weeks, and I think this is going to get even more complicated with larger groups in particular. So there's 2 ways of reporting. The first is that we report each clinician in our organization on an individual basis. So what that means is at the end of the year, whenever we do our actual reporting and attestation, we report each doctor individually with their own measures. So the good thing about this is that providers would be able to have more of an input to say, okay, I'm a provider and I want to choose these measures, and these are the ones that I feel I can personally do well with. They could also be standardized across the practice. So if we say, okay, we know that these doctors want to report individually, but as an organization, we feel these are the measures that we should create standard, they could certainly do that. Each provider would then be, their payment adjustment would happen based on their individual performance. And that's where I'm getting a lot of questions, where some providers don't necessarily want to be lumped in with the group, they want to do their own individual thing. And this particular mechanism would allow each of those individual providers to be judged based on their performance. The administrative burden to this may be relatively high, and that's why I wanted to just kind of put all the pros and cons to this element in there, because reporting, monitoring for each individual provider could be quite extensive. So it's going to be something you want to think about as you go through the process of selecting measures. Group reporting, the score is based on measures submitted from the group, regardless of specialty, and I think that's important. So if you're doing a group reporting, it's going to fall under your tax ID number. Whoever falls under that tax ID number, the measures are the same for that group. So if you have a large multi-specialty group, for instance, you're going to need to choose measures that make sense for your group as a whole. The payment adjustments are done on the entire group based on an aggregate of the performance scores. So that's just at this point in time, it's like a group exercise. Everybody gets graded based on the average score of the group. Again, you can select measures across the board. These are the standard measures that you're choosing from. There would be a lower administrative burden. The downside to this is that the higher performing providers, they may be impacted by the lower performing providers, or vice versa. You know, you're going to average that out as you go through the process. How do we submit quality metrics? So at the end of the year, we're going to need to send this data to CMS, and there's a number of different ways to do this. One is the QCDR. Those are typically tied into your EHR system. So for those of you using GE Centricity, I may have some other folks on the call as well, but GE Centricity uses the tool called the CQR tool, and that is a QCDR product. There are also certified registries. There are hundreds of certified registries out there that people could choose from. We can submit through claims, and we can also submit through the CMS web interface. Notice that beside the QCDR and certified registry, I have parentheses that say there's bonus points available. CMS calls those submission methods end-to-end electronic reporting. So by using one of those two, at the end of the process, whenever I'm tallying up all of my points, I can get bonus points if I'm submitting doing those things. It's perfectly acceptable to submit via claims if that's something an organization chooses to do. You just won't have bonus points available for that. Okay, so this section gets a little complicated, but I felt like it was important for us to understand this as we select our measures. So the scoring of quality measures, remember it makes up 60%, so it's pretty significant that we pay attention to how we're being scored. In the future, like in 2018, for instance, and forward, this component is going to be weighted slightly differently because the cost component is going to come back in, and there'll be 4 components of MIPS and not 3. But for 2017, it's 60%, so we want to really kind of pay attention to this area. Every measure will have a score from 0 to 10. So that's pretty straightforward, I think, from that perspective. Every measure that is reported in 2017, regardless of your performance, is going to get 3 points. So that's an important thing. That CMS has set that as sort of an average. So no matter what, if you report something, it can be a 0 performance, but you're going to get 3 points. So that's an important thing to know about. If you do not report on the measure at all, so if you report nothing, no quality measures, you're going to get a 0 for this component of the program. And then if your performance in the particular measure is good, if you have a higher performance, a higher benchmark, that score is actually going to increase. So you get 3 at a minimum, you can get all the way up to 10. This chart represents the scoring mechanism and how it's going to work. This is taken directly out of the CMS final ruling. If you notice in the second column where it has the sample benchmark, so this is assuming that you score, for instance, a 10%. Let's just assume that's your threshold. If you score a 10%, you're going to fall in the second column or second row where it says benchmark decile 2. Because of this floor that they have with giving us 3 points, you're going to automatically get 3 points. In the future, when they get rid of that, where we don't have this sort of safety net, you would have only gotten 2 points, somewhere in that range. The higher you score, so if you get up to an 80, 85%, you're going to get the 10 full points that you have available in the program. So those are things to kind of keep in mind as we're going through. We want to talk about, to get the most points, we want to do things that we can perform well at. So every clinician or group gets a base score for quality. And the way that this is calculated is we take the highest performing measure. So you can submit, we have a minimum of 6, but you could submit more than 6 measures. CMS will take the highest performing measures that you submit. They take that total and they divide it by the total possible points. Then it's multiplied by 60, which is the percentage that we have, for the weighted of quality. That will decrease, like I said, in 3 years, that'll be 50 and 40 and so on. And that gets us our total score for quality. So this is confusing as it's written down here. The next slide, I actually have a sample with real numbers so we can take a look at it. So if an eligible clinician reports 6 measures, 3 of them, they do really, really well, they get 10 points. 2 of them, they're in the middle, they get 7 points. And 1 measure, they just do the very minimum and they get 3 points. So the totals add up to 47 points out of 60, which were the possible, times 60, because that's our weight of the quality component, and that will equal the 47 points. So for 2017, this particular math is pretty simple because we're having the same 60 and 60, but that will change in the future again. So this algorithm as a whole needs to kind of stay in place because this is how it's going to work moving forward. So this person got 47 points as their score in the quality program. There are also bonus points available. So there's 2 types. There's the measure type bonuses, and then there's the measure submission method bonuses, both of which are capped at 10% of your denominator. The denominator is 60, for instance, so that means that 6 bonus points can be awarded. And these can be both. You can get the measure types and the measure submission methods. So you could actually get 12 bonus points if you maxed out on these. The measure type bonuses, you get 2 points for each additional outcome or patient experience measure, and 1 bonus points for high priority measures. So the way CMS has this written in the final rule is that if I'm going through and I select my 6 measures that I have to do, and there are extra measures that meet outcomes or they meet a high priority measure and I can accomplish those, if I report on them, I'm going to get bonus points. So you're kind of going above and beyond what the minimum is, and then you get the potential bonus points. And then the second part of that is the submission method. So back whenever I talked about how I'm submitting, and I talked about the QCDR and the certified registries, so each measure that I submit using those mechanisms, I get 1 bonus point. So if I submit 6 measures using a certified registry, I'm going to get 6 bonus points. The total quality score, this is important, it can't exceed 100% with your bonus points. So the bonus points aren't going to go get you, 110%. So whatever you're doing there as you're figuring out the measures that you're going to use, just keep that in mind. You can't go above and beyond 100%. Okay, so now that you have the measures, you kind of understand what they are, how they're scored, what do you do with that? We have to select our measures first. And that's the first thing we need to do. So before you select the measures, we have to go through and review what's available for your specialty. We also need to determine how you're going to submit the measures. And that's really an important factor, because if you're going to submit via claims, for instance, then you probably need to gear up a little sooner. If you're going to be using a registry, you need to go through the process of selecting the registry. And certain measures are not available for certain submission methods. So for instance, when you go through, if there are 100 measures to select from, maybe only 20 of them are available from a CQDR, for instance. So, there are things that you need to consider. So that submission method is really, really important as you're going through this process. How are you going to submit? It may seem like it's far off, but it kind of drives what measures you're selecting right now. Also, establishing any bonus points that you might want to go after. Maybe I want to look at additional high outcomes or high priority so that I can make a determination if I can get those extra bonus points to be available for my group. There's a website that CMS has available. It's actually a really good website if folks haven't gone there yet, I would highly encourage you. It's qpp.cms.gov. And then once you get there, if you go to the measures and quality, you'll be able to sort through and take a look at those measures. It allows you to sort by the specialty that I talked about earlier. You can sort on outcomes. You can sort on the submission method. There's lots of good things that you can do from that website. If you're still not sure what to do, as you've kind of gone through the process, talk to people in the field that are doing this, talk to your colleagues, look at your professional groups to see what they're recommending as measure selections for groups like yours. And then just keep in mind that this is going to impact your payments for 2019. So we want to do this. This is an important step because this is 60% of your score, and it's going to definitely impact 2019 and then forward as we go through with the quality improvement section. After you have your measures selected, then you have to put those into practice, right? So we got to figure out how we put them into our EHR systems, how we incorporate them into our workflows. There will be areas of your system that might need to be updated. You might need to update templates, custom list orders, things like that we need to make sure that whatever measures you select, that we review them, we understand the numerators and denominators and the importance behind them, and update your systems to make that work. We want to strive to make the workflow seamless to the end users. CMS set this tone at the very beginning of this presentation where they said they really do believe that the measures can be incorporated into your daily workflow. We just have to find a way to make that so that the end users aren't necessarily, your nurses and your MAs, that they're not impacted directly. If there's something they're already capturing, let's just figure out how to incorporate it into your system as efficient as possible. Providing prompts, using the system to kind of say, this patient's overdue for a PHQ-9, and that's a measure that we're looking at. So let's figure out how to really use the system to guide the providers and their staff to say, this is what we need, this is what we need to accomplish, and this is going to improve the quality of our patients. And then just adjusting those workflows and providing training as much as possible. We have a sample EHR tool that we have been working on with Health One. Again, this is just a sample just to kind of show you a little bit of what you might have available for options. This is bright and red, and just wanted to kind of call out a couple of things that we could talk about on this particular webinar. So in this column, we have numerators and denominators, and you'll see like red X's or green check marks. And it's basically just showing compliance with a measure. So if there's a green check mark, that means I did it. If there's a red X, that means it hasn't been done. Also, notifying providers when a patient might be excluded from a measure. So you may have selected the 6 measures for your group, but the patient doesn't necessarily fit into that denominator all the time. So we felt like it was important that for any given patient, if they don't meet the criteria, that the providers know, okay, I don't have to do anything on this patient because they don't fit in the denominator. So that's where they're excluded. And then allowing users to enter information quickly and easily from this screen. So if it says I need a BMI screen, I should be able to document right here. I shouldn't have to go anywhere else. Another example that we've been working on is putting something where at the very beginning of the visit, you have quality gaps. So it comes up and says, these are the things the patient's due for. So it's slightly different than the dashboard you saw in the first one. The first one is, here's all the measures. This is where the patient falls into. It's sort of a standalone form that people go to. Some people like that, some people don't. So I wanted to make sure that you guys had options to think about as you're incorporating these into your system. So this is something where there's a dashboard and it just says, this patient is due for these 5 things. One last thing is, if you notice on the right side of this screen, there we have that same sort of dashboard that this is what the patient's due for. So this is an interactive banner that we allow to follow through the visit of the patient. So if you notice, my person is due for a BMI on this screen. If I click the BMI, it's going to take me to my vital signs, and then I can enter a height and weight, and it'll calculate my BMI. When I do that, it now removes itself from that right-sided banner, so that I no longer know that that doesn't need to be completed for my patient anymore. And then if I were to go to that standalone form, the one that I showed first, I would see that that green check mark is there in front of that particular measure. Okay, so that concludes the deep dive review of the quality metrics. Our next webinar, we're going to talk about the advancing care information measures. In that webinar, and again, remember, advancing care information is mostly about meaningful use. It's very similar to it. So we'll talk about all of those metrics and measures and what they mean to you as an organization. I will probably do another quick recap of quality as well, just so that we are kind of keeping the theme of the webinars as a whole. Thanks, everybody. Have a great day.